I'm going to talk about two main areas of research that we do. One is on changing behavior, and the other is on predicting behavior using technologies. I'll use this as a story many of you may have heard. In middle of 2015, early 2015, there was an outbreak of HIV in a small area of Indiana, a place called Austin, Indiana. And it really came as a surprise to, like most outbreaks, it came as a surprise to researchers, to public health workers. Why were so many cases occurring? It started with 5 cases and then 10 cases, ultimately 200 cases in this area of about 4,000 people. And what we learned from that is that we learned a number of things about epidemiology and about what was happening, but if there had been a way to be able to monitor, record the spread of disease faster, to be able to predict spread of disease, and really to intervene, then we could have saved a lot of HIV transmission cases. And so what I'm going to touch on today are 2 methods that we've used. I'll use HIV as an example in a number of them, but also other areas outside of HIV. And I'll talk about, one, how we can use technology to change and intervene, and also how we can use it to predict different public health outcomes. So first I'll talk about one of our interventions. You've heard about different types of technology-based interventions today and yesterday. I'll talk about one of our core interventions, which is a social media-based intervention called HOPE, which stands for Harnessing Online Peer Education. The way HOPE functions is we have an online community. We recruit participants who are at risk for a public health problem, for diseases, and we have them join a private, secret online community. And then we train peer leaders in the epidemiology and how to reach out to strangers through online communities to change people's health behaviors. So it works similar to a diffusion of innovations model, but with a little twist as we're doing this with private online groups. We started doing the work on Facebook, and what we've actually found is there have been patient privacy issues. We just heard about privacy. There have been privacy issues with Facebook. There have been different concerns, and so depending upon the type of study, we might use different platforms for this. And through interviews with patients, we figure out what patients want. And so here's one that we built ourselves called Health Check-ins. And Health Check-ins takes a lot of the elements, is very similar to a Facebook group in a lot of ways, but it also incorporates a lot of the methods and processes we've learned are important for our health behavior change interventions. The way the HOPE intervention works is that we recruit peer leaders. So in the case of HIV, we recruit African American and Latino men who have sex with men who are at risk for HIV. We train them at UCLA in how we can use social media to reach out to strangers and try to change their HIV risk behaviors and increase HIV testing. And then ultimately in these private secret groups, what we find is that participants themselves start taking on the role of peer leaders, and the intervention starts diffusing or spreading to other participants. So I'll talk briefly about some of the results that we've had with those studies. So this was our first study that we did, and this was focused on HIV among African American and Latino men who have sex with men, MSM in Los Angeles. And we randomly assign participants to a control or a HOPE intervention group. It was a 12-week intervention where peer leaders were assigned to talk to participants and try to change either their HIV-related behaviors, risk behaviors, or general health behaviors. So general health behaviors would be stress, exercise, healthy eating, and the HIV risk behaviors, really the primary goal was to increase HIV testing. We used home-based testing for this, or self-testing kits. And what we found is that participants in our intervention group were about 2 to 3 times as likely as those in our control group to request one of these home-based HIV testing kits. We also found really high rates of engagement. So participants who are in our groups, there was 3-month follow-up, and then we had 1-year follow-up. At 3-month follow-up, we had over 94% of participants who were still involved, and 1 year after that, 15 months from the start of the study, over 83% of participants were still involved. And what we found with these communities is that we had really created organic communities, organic engaged communities, where strangers had come together and they really cared about each other. So this first community, I believe, was built in maybe 2009, and to this day, participants are still using it. The study's over, but we leave it open for people to interact with each other, and we still see them posting private, personal messages to each other where they're very supportive of each other. And we've then adapted this to other areas, and one thing that you find with online communities is that it's more than just an intervention, it's also a source of data. So if you look at this chart here, what you can do is look at what people are talking about over the course of the 12 weeks. And each of these columns is 4 weeks of that 12-week intervention. So as you'll see in the bottom left corner, there's friendly conversations. That's people they're invited to the group and they say, what am I doing here? What is this study about? Because they're just invited and they don't really know necessarily what they're going to be doing on the group. It's up to us to engage them and to try to change their health behaviors. So you see there's friendly conversation in the beginning, but each subsequent 4 weeks, friendly conversation decreases. And if you look at the top left, the conversations around HIV prevention and testing, those increase. So we can see that the intervention is having an effect. Over time, participants are beginning to talk more about their interest in HIV testing. And we'll see conversations that they share a lot of personal information. In the case of HIV prevention and testing, one participant said, I tend to feel that despite it all, being a part of this group would inspire each of us to get tested. I agree it's a personal responsibility, but on some level I feel it's a social one as well. Despite whatever your reasoning, it will remain a private matter unless you choose to divulge it within the group. But for all those who haven't, knowing is worth it in the end. Let's just do it. So that's an example of a participant who took on the role of a peer leader. And you can imagine and you can see how, as participants over time, more and more participants start speaking to each other in the online community like this, that it can really motivate the rest of the community and really be a powerful tool for health behavior change. We've applied these methods to a number of different areas and different sites. So here was a study that we conducted in Peru using very similar methods. Instead of the HIV self-testing, this one we partnered with a local community organization called Epicentro, and they had people come in to actually get an HIV test, and we found very similar results. So people in our intervention groups were about 2-3 times as likely to test, and we found, again, really high rates of engagement. We've also adapted these methods. We've been working with UCLA in our clinics and looking at how to adapt this approach, the HOPE intervention, among chronic pain patients who are on opioid therapy at risk for overdose addiction, consequences of opioid therapy. We started with interviews and found that patients really, they lacked a community like this that could help address their chronic pain issues and reduce their risk for complications from opioids. And we've since then just finished a randomized controlled trial looking at UCLA pain patients to see the effects of HOPE on addiction and opioid-related outcomes. Another thing we can do with studies like this is we can look at other types of outcomes. So one thing we found is in the HIV studies, for example, we found that participants who posted about HIV-related risk behaviors and intentions to get tested were 11 times more likely, 11 times the odds of actually requesting a testing kit. I think that's interesting. That'll probably be interesting to health behavior people here, as there's this question of should we use measures of intention? Intention doesn't necessarily lead to actual health behavior change, and maybe there's something different about expressing intention organically online, because I see that expression of people saying they want to get tested or they care about getting tested almost as an intention to test, and we found a pretty high relationship between expressing an intention to get tested and requesting a testing kit. You can also look at how people become friends with each other and how they connect with each other over these groups. And we found that people who became connected with another were also more likely to request an HIV testing kit, so the engagement was driving health behavior change. The other thing we wanted to do was see, these were all private, secret groups, so there was a question of how do we scale something like this? Each group had about 25 to 30 participants, and we had multiple groups, but how do you scale something like that? Do you have 50 different groups of 30 people, or is it possible that the people in these online communities will start sharing it with others outside the community? And we weren't able, because of IRB and ethical issues, we can't go and, even though we had access to who they are friends with and connected to outside of the group, we can't directly contact those people. So what we did is we invited participants in the group to invite their sex partners and their friends to complete surveys on whether they had heard about the HOPE intervention, whether it influenced them. And we found that the majority of those who responded to the survey had heard about the intervention, and that it had discussions with their sex partners or friends had an effect on their health behaviors. So in other words, the intervention, even though it's localized into these online community groups that are small and private, it was spreading and diffusing outside of them. So I'm going to switch topics now. That concludes the talk on one way we can use online communities to change behavior, and now we'll get into the second topic. Who knows what this is? Moneyball. Okay, what is Moneyball about? I heard a little bit over here. What is that? Baseball. 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 You guys are quick answers here. Who? Yeah. What's your background? What's your Are you? What's your area of study? What did? Policy, environment stuff. Okay. Just asking here. People, when I ask this question, people, depending upon their background, they'll say, "Oh, it's about baseball." The sports people obviously say it's about baseball, and they'll go in a lot of detail of the history of